Hello and welcome to the Healthcare Today podcast. Our guest this week is Cardiff University's Professor Daniel Gartner, a specialist in operational research and healthcare modelling. Every day, the NHS performs a logistical miracle, organising thousands of appointments, emergency calls, surgeries and discharges. However, anyone who has faced a long waiting list or a cancelled clinic knows the system is under immense strain. We often assume the solution is simply more staff or more money. But what if the NHS is already sitting on a hidden goldmine of untapped data that could predict delays, recover missed appointments, and improve patient outcomes without a single extra doctor? Today, Daniel Gartner will show us how maths, not just medicine, might be the smartest way to save the NHS. What does operational research actually mean when you walk into a hospital, and what is the day-to-day reality of an operational researcher inside the NHS?
So the Operational Research Society in the UK defines operational research as the scientific approach to analyze complex problems, make decisions better with analytical methods, for example, applied mathematics. And when you walk into a hospital, you don't really see that, all the equations, etc., on the walls, of course. But behind, there are operational researchers that really support the planning of these hospitals. That means where to locate a hospital. What does that mean with the demand coming in? Do we have enough capacity in the theaters, in the emergency department, etc.? And staff rotas, do we have enough staff there, workforce, etc.? So all these things are connected or put into equations, and then we would solve these equations using all the algorithms, talk about AI, etc., that is available now to solve these models and make better decisions. That means providing executives or managers with the optimal solution then, and a trade-off between alternative A, alternative B. Should we go with higher capacity here or lower capacity there? What does that mean in terms of cost, in terms of beds, etc.? So all this is kind of balanced out and provided to a decision maker. That's what operational research kind of stands for. Mm-hmm.
So let's talk about the huge amounts of underused data that the NHS is sitting on. What kinds of data are we talking about? Is it appointment history, staff rotas, is it bed occupancy? And why is so much of it currently being ignored?
It is, as you say, rightly, all of these types of data are relevant for these models to make ultimately these decisions better. In terms of ignoring the data, I think these days people try to harvest as much data as possible, but the issue is often that it's not interconnected. So you have a staffing rota on a Wednesday, which doesn't really talk to the appointment history that we had on a Wednesday for patients 1, 2, and 3, etc. Sometimes we would not get the exact member of staff at that day who was on shift, or have other issues. That was that a missed appointment, yes or no? So all that is as good as possible in terms of capturing in the data, but we often talk about silos and that these data pockets don't talk enough to one another. I mean, it's like in the airline sector, for example, that you have a rota of your staff, of pilots, but you don't really connect that with a customer. So that is a problem of an information system that in the future hopefully is then more interconnected with one another. But that makes the modeling hard. So there's always that manual work that you have to do as an analyst, for example, to link these different pockets of data and make meaningful assumptions that your model then gives the best possible decisions at the end.
You've worked on NHS projects where your models have improved efficiency and patient outcomes without adding a single extra doctor, nurse, or bed. Was there a particular hospital department where your model identified a hidden bottleneck that nobody had spotted? And if so, what did the data reveal?
Yes, that is a really good question. So we had an exciting project in respiratory where we were thinking, or we had to balance out new patients and follow-up patients. So if you accept new patients in your system, then obviously that has an effect on the follow-up patients. So, for example, if you have one respiratory patient that you admit, then that means they have several follow-up appointments down the line, every 3 months, 6 months, or every year, depending on the condition. But when we were talking to our clinician and showing the mathematical model then behind the analysis, then we found, or that explained actually their a current situation that they had accepted too many new patients that created that bottleneck for the follow-up patients. So that doctor, unfortunately, was in that hamster wheel that they had that long new patient list and were always or lots of times accepting these new patients. But then that means a couple of months later that they had to run through all these follow-up patients, and that created that hamster wheel and issues in the entire system then, which was something that probably a mathematical model could have shown beforehand, but because they were in a situation where they didn't know how to analyze that, that helped then, of course, understanding their system better and, have a good or a healthy new to follow-up ratio for new and these follow-up patients' demands.
So, looking at recovering missed appointments, how does predictive modelling, or indeed can predictive modelling, identify which patients are likely to did not attend? And what can a hospital actually do with that prediction before the appointment slot is wasted?
So there was another exciting project with head and neck cancer, which is now rolled out to endoscopy. So we were predicting or helping the service predicting which patients are more likely to not attend the appointment or who is more likely to attend. So we found out that there are some clinical and demographic variables that would be useful. Then we have the Welch index of multiple derivation, for example, that we put into that as well. But at some days in the week, it turned out, and even sometimes during the day, it would turn out that patients would rather not turn up to the appointment. But there is also patients that already missed a couple of appointments that would be then even more likely to not attend the new appointment coming up. So things like that were put into the analysis. But at the end, what can you do to make sure that these patients have a higher likelihood to attend these appointments? That is, if your model then shows, okay, there's a high likelihood to miss the appointment, you would then follow up, like ringing them. And then that was a really interesting patient story that we had. So our consultant then shared the story with us that the service then was ringing a patient. Their daughter picked up because the mom said, "Oh, that is NHS calling me over and over again. I don't know what they want." But the daughter said, "Mom, but you should really take that call." And the daughter picked up, and that was actually the invitation for that appointment. So the daughter told the mom, "You should actually go to look after that lump you have for head and neck cancer. So you should really go there." And that made that difference because the NHS were calling that mom to go to a appointment. That changed the behavior. I'm not sure whether the patient was then saved with cancer, but it was then making a positive impact and difference for using then our mathematical model or prediction model then for these patients.
There's an understandable fear that efficiency means treating patients like factory units. By that I mean faster but colder. How do your models balance the drive for operational speed with the need for compassionate, individualized patient care?
You can build these models with very detailed, and the mathematical model become more and more detailed these days. So you can, like in a scheduling model, for example, you can really individualize your algebra to these patients. So that means every patient comes with clinical characteristics, demographic characteristics, where they live, what appointment history they have, etc. So you can really individualize more and more these patients with their multiple conditions requiring this and that type of resources along their clinical pathway. But yeah, at the end, it's probably a balancing out whether you would like to have reducing your new patient list, for example, or going more into the follow-up list reduction, or having more resource utilization, or less waiting time, etc. So all these metrics are then the decision makers on their table and their responsibility to use these models wisely and make a better decision and trading off these different performance metrics that you have. So it's not a one size fits all. It's just a nuanced understanding of these models and making these decisions so that at the end of the day, the patient gets the best care that they deserve.
Looking at outpatient services where many delays do start, what's an example of a specific change that you've modelled? One that specifically benefits both a busy consultant and, say, a nervous patient?
So in ophthalmology, for example, we had the different patient characteristics. They come with a referral to treatment time. For example, they have been waiting 4 weeks or 6 weeks for their appointment, and then they have their eye care measure, like a risk factor, whether if you have a glaucoma or something that is getting worse and worse, then you also have that kind of a clinical measure for the mathematical model to fill in. But on the other hand, on the capacity side, you have the different clinics for your consultant, the different length of these clinics, how many staff you have, etc. So all these are then broken down different days and weeks of the planning horizon. But what a model can do now, it can show you how you have to staff that capacity compared to that waiting time reduction in referral to treatment time, or how much increase in number of patients you can have on the different eye care metrics or eye care measures. So that is what the mathematical model can tell you then, and balancing out that patient stress, but also consultant stress somehow.
Okay, so we've talked about what data and modeling can do, but where do these models fail? If not fail, kind of don't keep up. Is there a type of a healthcare problem, perhaps something highly unpredictable like a pandemic, say, where the modeling could be a detriment rather than an asset?
This is a really good question, because usually you would run these mathematical models or operational research models without taking too much into account all these disruptions like the pandemics. But interestingly, in the pandemic, we were asked again with these models to refine them and make these short-term predictions on number of staff that we need, and what services have this and that capacity in the pandemic. So the models that you run really on a strategic scale, like, the next 5 years or 10 years, where to locate the hospital, etc., that is then put into the next level, into operational models, where you then have to fine-tune all these different decisions. So there are different models for different types of planning problems, but in a pandemic, for example, you would rerun and refine these models and come up with new solutions. So a long story short, I don't think it's a one-off modeling issue that you try to solve. These models are refined and used over and over again to adjust capacities and predict demands again. Different models have different advantages when they are used, and different decision levels.
Crystal ball time. If you had 24 hours, for example, of unfettered access to NHS England's data, what's the first problem you would try and solve with your models?
No, that is a really, really good question, and also really difficult to answer because of the fragmentation of the different data sets and the different types of problems that there are. I would probably say I would go back to my consultant and look into the no-show prediction and no-show modeling, and just learn whether other service can use that and run or create a new mathematical model for other service to benefit from that head and neck cancer and endoscopy work. So running that as well again. Or I would maybe also revisit other projects like our intersite transfers, where we were able to show an improvement in having a better transport service for patients who go from one hospital to another. I think there are multiple problems that I would like to revisit again and rerun the models and just check what change happened. Yeah, so there are so many exciting problems that probably 24 hours is not enough.
Well, exactly. Rome wasn't built in a day, and the NHS would take a lot longer than 24 hours to fix. So,
Absolutely.
slightly loaded question there. Finally, what's the one misconception about NHS data and efficiency that you wish that policymakers and the general public, by extension, would stop believing?
I think with the advent of AI and how much it is used these days, I think I don't think all the AI problems or the demand and capacity planning problems can be solved using AI alone. So there always needs to be that analyst and the modeler behind that checks all the assumptions, verifies and validates the model, and goes back into whether additional data is needed, and is the data clean, for example, because so many times you see that you need to make assumptions on the data tells you one story, but in reality then a different story is actually, or the different situation has been taking place. Even when you look into staffing rotas, that was actually planned. Then sometimes, you have people who are off on annual leave, sick leave, or study leave, etc. So that is sometimes not captured in the data. So there's a lot of data is available, but the reality is often not exactly in the data. So that is where also AI models would fail, because you only capture what you see in the data, but it's not really often the reality recaptured in that data. So long story short, I would say, be careful in trusting all the data that you have. You just have to spend a little bit more time to look at what is happening in reality.
Absolutely. Professor Daniel Gartner, thank you so much for your time.
Yeah, you're welcome. Thank you for having me.